Right. Okay. This is, like sir has said, this is part 2 of oral cancers. Part 1 was fairly long time ago, actually near more than 2 weeks. And a lot of things have happened in the past 2 weeks. Some pleasant, some not so very pleasant. The pleasant one was Professor Udwadia speaking, and like an icon in surgery. Very nice to hear Professor speak. The not so pleasant thing was I lost a friend, a colleague, a surgeon from Chennai. Some of you probably heard his name. Dr. Suraj Balaji was a very dear friend, and we lost him to stomach cancer. So not very pleasant. Dr. Patta was saying, I'm a little busy. I'm not. I'm just lazy to sit and make these slides. So with that as the background, while Corona is being rampant and Chennai is in lockdown, we'll continue part 2 of oral cancers. This was where we stopped last time. There is an upgrade of the TNM classification according to the AJCC 8th edition. Few things have changed. The T2s have become T3s, the T1s have become T2s, etc. We try and find out what it is. As we start, usually we start with a question. I have a question for you. A patient has T4 oral cancer. Another patient has a T4 breast cancer. Stage per stage, who does well? I'm waiting for answers. T4 oral cancer patient A. Dr. Tyagarajan, hello sir.
Hello, Dr. Srinivasan, sir. My name.
Sorry.
How are you,
Yes,
sir?
How are you, sir?
Hope we missed last.
I'll just ask you a question to the students to get things going.
Yes, sir. Thank you. Thanks to Radhakrishnan, sir, also.
Yes, yes, sir. Yes. Anybody can answer, please. There's a patient with a T4 oral cancer. Stage by stage, patient with T4 breast cancer. Who does well? Overall survival. We have people listening, or? Do we have postgraduates listening, or everybody muted their mics? Hello? Can you guys hear me?
It must be a difficult question, I presume, since nobody is.
Not very, sir.
Someone's typed in the chat saying breast.
I'm sorry?
Someone's typed in the chat saying breast.
Breast cancer is better. I don't know who's speaking, but does it say that T4 breast cancer people behave better than oral cancer, or is it the other way around? Well, there are certain basic differences between oral cancer and breast, and one of which is oral cancer is a loco-regional disease compared to breast cancer, which is a systemic disease. So if you believe in that, which is true, T4 oral cancers behave much better compared to a T4 breast cancers. The living example, I don't know how many of you people have heard or seen Mr. Sharad Pawar. Sharad Pawar is an ex-defense minister of this country. He's been operated twice for, I think, a cancer of the lip, somewhere around that region. Though he's got a very visible deformity, Mr. Pawar is alive and kicking. So T4 oral cancers behave differently compared to a breast cancer of the same stage. This one is not moved. Give me a minute. My slides are not moving. Just give me a minute.
You click on screen, sir.
I'm trying. Let's see one. Yeah, fine. Okay. Something happened. Right. Okay. Right. With that, we look at the TNM. Before we go on to the actual TNM, there are certain sub divisions for CNM, what is called the small c, the small c, the small y. The small c and the small p are more familiar. Small c stands for the clinical TNM staging. The small p stands for the pathological TNM staging, which usually upstages. You operate and then send the specimen to the pathologist. The pathologist usually upstages the disease. What's the small y TNM? Don't write in the chat box because I can't see. You'll have to answer, please. Somebody answer. What's the small y TNM?
Post chemotherapy.
Need not be chemotherapy itself. Any adjuvant therapy that is given, you restage the disease, becomes a small y TNM of importance, especially in oral cancer sometimes. This slide is a revisit of the slide which I showed last class, depth of invasion versus tumor thickness, because today, according to the TNM classification, is based on this, the depth of invasion. And the depth of invasion is called DOI, is the vertical height measured from the basement membrane, unlike the tumor thickness, which is the total thickness of the tumor. It said initially when they measured the DOI, they said more than 5 millimeters / 10 millimeters, survival became poorer, which is why when we discuss the T, we'll find out how important the DOI, or the depth of invasion, is. Look at the TNM. TX is when the tumor cannot be assessed. Let's say post-neoadjuvant therapy, can't find out where the tumor is, that becomes a TX. T1 is less than 2 centimeters is what all of us read. What's added in the HSCC 8th edition is this. It must be less than 2 centimeters, but the depth of invasion must be less than or equal to 5 millimeters. So strictly speaking, this is a small p TNM. Though there is a controversy which says if you do a biopsy, is that enough? There are people who argue for and against, but strictly it must be a small p TNM. Suffice to know at this stage, less than 2 centimeters is what was the old classification. What is added is the depth of invasion must be less than or equal to 5 millimeters. T2 becomes when the depth of invasion increases to between 5 and 10 millimeters, the size is less than 2 centimeters, or you find that the tumor itself is up to 4 centimeters, but the depth of invasion is less than a centimeter. To simplify, if the depth of invasion is less than 1 centimeter and the tumor is less than 2 centimeters, it is a T1. Anything up to 4 centimeters, that is 2 or 2 to 4, but the depth of invasion must be less than 10 millimeters or 1 centimeter, becomes a T2. What's a T3? When the depth of invasion increases to between 1 and 2 centimeters, that is 10 and 20 millimeters, usually the size is more than 4 centimeters. These are mutually exclusive. That is, you can have a tumor which is more than 4 centimeters, becomes a T3, or you have any tumor with a depth of invasion between 1 and 2 centimeters, still makes it T3. T4 is divided into T4A and T4B. Moderately advanced means invasion of adjacent structures, or the depth of invasion, that is the DOI, is more than 20 millimeters. So anything up to 20 millimeters still becomes T3. The minute the depth of invasion increases to more than 20 millimeters, becomes a T4A with invasion of adjacent structures. T4B is very advanced, skull base, internal carotid, or the pterygoid plates in the infratemporal fossa. Can we proceed? From T, can we proceed to N? Yes or no? Somebody please answer, because we're getting stuck.
Yes, sir.
Right, okay. So that's T. So we'll go on to the N. What's new in nodal status is ENE, that is extranodal extension. That is new. N0 when there are no nodes. NX is when you cannot assess the nodal status. N1 is a single ipsilateral node which is less than 3 centimeters. This is what we learned. What is new is added that there should not be extranodal extension. So it's not enough if you have a lymph node which is less than 3 centimeters in size. There should not be extranodal extension. I'll tell you a way to remember this because it becomes a little complex. N2 is further divided today into N2A and B and C. We'll find out what it is. The node may be less than 3 centimeters. However, if the extranodal extension is present, it upstages to N2A. So you have a node which is less than 3 centimeters without an extranodal extension becomes N1. The minute you have an extranodal extension get upgraded into, upstaged into an N2A. An N2B, you have multiple nodes on the same side which are less than 6 centimeters without, I repeat, without extranodal extension. An N2C is either a contralateral or a bilateral node without an extranodal extension. So if the size is less than 3 centimeters, you have ENE positive, makes it an N2. Otherwise, the size must be between 3 and 6 centimeters. And N3 is changed if you have a node which is more than 6 centimeters without an ENE. And N3B is an ipsilateral node which is more than 3 centimeters, however, with an extranodal extension. Sorry, more than 3 centimeters, yes. Or you have multiple ipsilateral, contralateral, or bilateral nodes, an extranodal extension. And if you have any size of a contralateral node with an ENE positive, makes it an N3B. So to summarize, the minute you have an extranodal extension, the node status gets upstaged by 1. U and L, according to the new classification, depending on above or below the lower border of the coit, they've defined a selective neck dissection must have at least 10 nodes. The number is changed as we go on. Or a functional or a radical neck dissection must have 15 plus nodes. I'll tell you the exact number. If you have inadequate number of lymph nodes in the pathological specimen, they still call it a PN0. And there was a question asked last time, somebody is going for an exam. If you have midline nodes, what to do? It's classified as the ipsilateral side. This is stage by stage representation, a single slide, starting from stage 0, going on to stage 4C. The minute there is a metastatic disease becomes 4C. The minute there is a T4 lesion, either a T4A or a T4B, again becomes a stage 4, I'm sorry. And then subsequently, the other relevant stages. Stage 1 becomes a T1 without nodal disease and a T2 without a nodal disease. Can we go on?
Yes, sir.
Right, okay. That's the AJCC-TNF. Right. I want you to read this article if you can get. This is OPC stands for oropharyngeal cancers, a beautiful article published April 2017, wherein a lot of things are new for me. I'm not discussing this in detail except for a few things here and there. There is a separate staging system according to that article for human papillomavirus. HPV is human papillomavirus associated oropharyngeal or tongue-based cancers. Occurs in younger and more healthy individuals, and this is a little worrying. There is no risk of tobacco. There is no tobacco exposure in people with HPV-associated oropharyngeal cancers, but they say the prognosis is good with excellent response to treatment. And a word about the human papillomavirus. Sorry, this is new also. 90%, up to 90% of unknown primaries, what in surgical jargon is called the MUO, or metastatic or unknown origin, represents, they say, associated, HPV-associated oropharyngeal squamous cell carcinomas. So the next time you have a patient with which is labeled as an MUO, kindly be careful, look for HPV infection, that is human papillomavirus infection, how do you look for? You do an immunohistochemistry to look for the P16 status, the tumor suppressor protein status. It's established as a reliable surrogate biomarker. That is, if you have raised P16 levels, probably the individual has been infected with the HPV. And it says it's an independent positive prognostic marker. That is, if your patient is HPV infection, the prognosis is probably better, as I've already told you. We come to treatment. Basic tenets of treatment will be surgery, radiotherapy, chemotherapy, and in addition today, immunotherapy. Let me ask you a question. There is a T1 lesion in the buccal mucosa, N0, M0. Surgery or radiotherapy? T1, N0, M0, buccal mucosa. Will you operate or will you irradiate?
Radiotherapy, sir.
Radiotherapy. Why not operate? I don't know who's answering, so it's okay. Why not operate? I'm surgeon.
Surgery, sir.
Surgery. So why not give radiation? Both ways I'll ask you the same question.
Because if there is a recurrence, we have to give radiation. So it's better to go for surgery, sir.
If you irradiate, it does not recur?
No, sir. If at all there is a chance of recurrence, he may go in for the maximum dose of radiation, sir.
So if you give maximum dose of radiation and then the patient recurs, what to do? Operate?
Then there is no other go. We have to do surgery only, sir.
Okay, right. Are you aware, my friend, that operating after radiotherapy is that much more difficult because of fibrosis? Right, okay,
Yes,
we'll
sir,
try
it
and
is
find some
difficult.
answers. The point is this, the point is like a surgical oncology friend of mine who very elegantly put it. He said, it depends, the surgeon, the patient who going for treatment will get, depending on where the patient goes. If the patient goes to a surgeon, the surgeon will operate. If the patient goes to a radiation oncologist, radiation will be given. The point is, squamous cell carcinomas are very radiosensitive. So early stage, it doesn't really matter whether you operate or you irradiate, depending on what your philosophy of treatment is. Immunotherapy is a little controversial at the moment, is accepted by some medical oncologists. Pembrolizumab is one of the things that are used as immunotherapy. But today, immunotherapy is given only when everything else fails. That you can't do anything else. Like my friend said, you give the maximum dose of radiation, he said. So immunotherapy today is kept for the end. These are some terms which are used commonly in oncology: adjuvant, neoadjuvant, and palliative. The difference, please. What do you mean by adjuvant, neoadjuvant, or palliative? Somebody please answer.
Adjuvant is when R0 resection is not nearly possible, sir. And neoadjuvant is for downstaging the
Let's say,
tumor.
but my point is, I am not very sure that I know what an R0 is. That's my next slide. Something is introduced a term called R0 resection. I don't know what that is.
Based on the final histopathology.
What is neoadjuvant, you said?
For downstaging the tumor.
Downstaging the tumor. What do you do? Operate.
Yeah,
Is
after
that,
downstaging the tumor based on the
I'm asking,
response strategy.
is there
Based on
neoadjuvant
the
surgery or neoadjuvant chemotherapy?
neoadjuvant chemotherapies.
Only. So if you
Yeah.
if you give chemotherapy and downstage the tumor, it is neoadjuvant, is it?
Even radiotherapy also we can.
What is palliative then?
When resection is not possible,
Okay.
Then
Little
There has to be a curative intent for.
great. Okay. There's a little bit of a difference in basic philosophy. Adjuvant and neoadjuvant are terms which are used when you want to cure the patient. When the intent, I repeat, is to cure the patient. Palliative is when cure is not possible, right? Commonly, people mistake that if I give chemotherapy first and then operate, it is neoadjuvant. It is not always true. Let me give you a small example. There's a patient with a carcinoma stomach in the pylorus with multiple liver metastasis. I cannot operate. So what will I give? I'll give chemotherapy. In the course of the chemotherapy, the patient starts vomiting and I'm forced to operate. And what will I do? I will do a bypass. These days you can put an endoscopic stent. But before that, we used to join the stomach to the jejunum called a gastrojejunostomy. Here, I've given chemotherapy initially and then I've operated. But this is in a patient who has liver metastasis where cure is not usually possible. So even if you have given chemotherapy and operated, in this setting, it becomes palliative. Understand? There's a little bit of a difference between adjuvant, neoadjuvant, and palliative. Yes or no?
yes, sir.
Right. Okay. Fine. Now we come to what the gentleman said. R0, R1, and R2 resections in oncology. Depends on an R0 resection is what you must aim for. An R0 resection is you operate and then send the specimen to the pathologist, which you should. And the pathologist tells you, look here, all margins are clear from tumor. That is an R0 resection. An R1 resection, and repeat, an R1 resection is when you operate thinking you've done an excellent job, you've taken out the entire tumor. To your utter misfortune or surprise, the pathologist tells you, my friend, there is tumor still active, there is still tumor in one of the margins that you have resected. That is, macroscopically, the tumor is, margins are clear, but microscopically, there is tumor. That makes it R1. And R2 is what you should not do. When I operate itself, I know I have not taken out the entire tumor. That becomes an R2 resection. So if you have macroscopy and microscopically tumors which are clear margins, that becomes an R0. The worst is an R2 resection. What is the surgery usually done for oral cancers in general? I will give you the overview. I thought it's good to divide what you operate depending on what we do for the primary tumor, what I do for the bone, and what is done for the neck. If you divide this, life becomes a little easier. Otherwise, it's a mess. What are the principles of surgery when you operate for oral cancers? You must have clear margins from the edge of induration. A tumor may be 3 centimeters when you inspect, but there is a nice 1 centimeter of induration around the edges. So the margins must be measured, surgical margins must be measured from the palpable edge of induration and not the visible tumor. The basic of any surgery for oncology is clearance of oncological. And what has changed recently is the next two. If we can achieve oncological clearance, the other two become important. That is, we try and preserve as much of function of the oral cavity as possible. And last, but most important for the patient, is cosmesis. So what has changed is this. When we were students, when we were postgraduate students also, we looked only at this. I want to clear the malignancy. Doesn't matter how the patient looked like at the end of the operation. Doesn't matter if he or she did not have an oral cavity which was useless for everything. We looked only at oncological clearance. But these are two which are equally important, I think. If you can achieve oncological clearance, the other two things also need to be looked at. Historically, we were told there's something called this. There was an operation called a commando operation, which was a composite resection or a monoblock resection. Everything came out. The tumor, usually involve bone, the mandible, and a neck dissection. Of course, this was after the spy novels that we read, the Western novels that we read, in Operation, the commandos, who went to war and came back disfigured. So unfortunately, while you did a fantastic job in clearing the cancer, your patient looked something like this. If the mandible got removed, it gave a very unsightly deformity. Here there's some reconstruction which is done, but once the mandible was removed, once the jawline was altered, the patient looked terrible. He or she survived, but a very high price had to be paid at the end of this commando operation. So we tried and looked whether things can be done better. And one of the things was this. What do we do today for the primary is what is called wide excision. How wide? Trauma induration, what margin? What's the margin I need to keep?
1 centimeter.
1 centimeter. True. Most people will agree with 1 centimeter, but there are instances wherein, depending on the tumor characters, you can get down to 5 millimeters. But otherwise, 1 centimeter should be accepted. Is needed, sorry. In the tongue, that usually means various confusing terminologies. There is a partial glossectomy, a hemiglossectomy, a total glossectomy, etc., etc. But at the end of all that, it is true that if you take out more than 50% of the tongue, some amount of some sort of reconstruction is needed. I'll show you some pictures. There's a confusion between what is a partial glossectomy, what is a hemiglossectomy, etc. I'll show you. These are some pictures which, anywhere from the net, a portion of the tongue is removed. Here it's primarily sutured. Person is extremely lucky, whereas here there's a nice cheek flap which has been put or something rotated from the floor of the mouth. I urge you to read this paper. This is a 2019 paper, yes, which classified glossectomies into 5. This is a type 1 glossectomy or a mucosectomy. The area which is shaded in blue is the portion of the tongue which is removed. Important to note that the tongue musculature is not removed. Usually not good for tongue cancers, only for pre-malignant lesions. This is useful. They call a hemiglossectomy a type 3A glossectomy, wherein, or a type 3B glossectomy is what is called a compartmental glossectomy. If you take out any portion of 1/2 of the anterior 2/3, things are become a little confusing. This is the anterior 2/3 of the tongue. This is the right half of the anterior 2/3. The portion in blue is the portion of the tongue which is removed. So according to that paper, a type 3A hemiglossectomy will be any amount of the half of the tongue is removed. Doesn't matter if you spare at the tip or near the back. More important, near the tip, if you can leave behind and still call it a hemiglossectomy. A type 3B is a more extensive compartmental glossectomy. And this is a picture of a total glossectomy, where the entire tongue, including the posterior 1/3 of the tongue, is removed right down till the base of the tongue. Somebody was asking what's the difference between the base of the tongue and somewhere along the posterior 1/3. So if you take out the entire tongue, becomes a total glossectomy. A question: can the patient talk after a total glossectomy? Yes, no. Can a patient talk after a total glossectomy? Yes or no? Yes or no?
Yes.
Yes.
Yes. Only thing is you can't pronounce certain vowels, etc. You cannot pronounce. It's called a laryngeal speech. So nothing to do with the tongue. So that becomes a type 5 or a total glossectomy. What about reconstruction? Just touch upon. You can rotate either a cheek flap, which a general surgeon can do, an anterolateral thigh, or a free radial forearm flap. Obviously needs more expert plastic surgery expertise. These are the most common reconstructions done for the tongue. I'm confining myself to tongue and neck. because otherwise it's just too extensive a topic. What about the bone? Either the mandible or the maxilla. We forget that occasionally you can have a hard palate lesion which involves the maxilla. The mind thinks of, the minute you talk of oral cancers, the mind only thinks of the mandible, and that is important also. In the mandible, the most common operation was a hemimandibulectomy. One half of the mandible came out. Oncologically very good, cosmetically not very good. So this concept about a marginal mandibulectomy came out. These are certain pictures of portions of the mandible removed. This will become one half of the mandible removed. This becomes an extended hemimandibulectomy. This becomes a segmental mandibulectomy, as does this. What's a marginal mandibulectomy is this. You try and preserve the outer table of the mandible and take out the gingiva with a portion of the mandible instead of this. The minute you do a segmental mandibulectomy, the jawline is gone. So that produces the cosmetic deformity. So you do a marginal mandibulectomy. What are the indications? I'll tell you what are the guidelines. So try and preserve the outer table of the mandible if it is oncologically acceptable. That's a marginal mandibulectomy. I quote from this paper. This is the 2019 May paper, Guidelines for Surgical Management. It says a mandibulectomy can be waived if the tumor abuts the periosteum of the mandible. If you have a sulcus lesion, that is, if you have a lower gingiva buccal sulcus malignancy, induration present on the periosteum of the mandible, you probably can avoid a mandibulectomy. You must consider mucosal periosteal resections, if the bone is not involved by doing an OPG. And this is important also. Marginal mandibulectomy is recommended, etc., if the tumor has not deeply invaded the cancellous bone. However, if the person has gone through radiation or is edentulous and the mandible is thin and you're worried it will break, a marginal mandibulectomy will not work. You must go ahead and do a segmental mandibulectomy. Here, cosmesis takes a back seat compared to function. So, what has changed is this. You can consider a mucosal or a periosteal resection without invasion of the bone, or even if it abuts the periosteum, try and avoid a mandibulectomy. You can do a marginal mandibulectomy. If it is oncologically acceptable, I repeat, and cosmetically, we can make the patient look a little less deformed. What about the neck? Such questions to answer. Is there a place for an elective neck dissection? That is the patient, and if the patient is an N0 neck, do I need to dissect the neck? Yes or no? Is there a place for an elective neck dissection? Yes or no? Nobody's answering. Yes or no?
Yes, sir.
There is a place. So every patient you do an elective neck dissection or certain indications?
Depend upon the thickness, depth of invasion. It is less
Right.
than 2 mm, then you can avoid. Otherwise, it is required as
Fair.
per the recent paper by the Cruz.
Not very recent. Okay, we'll find out what it is. So there is a place, like the gentleman says, for an elective neck dissection. Sorry, again some problems. Give me a minute. Right. Therapeutic neck dissection, no confusion. If there are notes, we will take out. What we'll take out, we'll find out as we go on. Is there a place to observe the N0 neck? Probably answered in part by the same gentleman. He said less than 2 millimeters. What it is, we'll find out. Or should we irradiate? These are certain questions to be answered when you're dealing with neck in oral cancers. We historically go back to what is called the Kryles. Everything today is compared against the radical neck dissection of Kryle. Basically meant everything between the mandible and the clavicle came out. the fat, the fascia, etc., between the mandible and the clavicle with lymph nodes levels 1 to 5. The submandibular salivary gland came out and the tail of the parotid also came out. Why? Because there is intraglandular lymphatics. Somewhere somebody was talking about how the gland develops and how the lymph nodes are encased within the salivary gland itself. So the salivary glands also came out in a radical neck dissection. Excellent operation it was from the oncology point of view. But then it had certain bad effects. Worst was cosmesis, of course. The carotids were exposed because the sternomastoid came out with the specimen. And then if you irradiated post-op, there was a chance of a bleed because the carotid was exposed. If you did a bilateral radical neck and ligated both the interjugular veins, venous drainage from the cranium, from the cerebrum became compromised, led to certain problems. Worst was cosmesis. So in an attempt to try to improve these things, we've in the era of the modified radical neck dissection called various names. For some of us call it a functional neck, some of us call it a modified radical. So today, the more fashionable thing is to call it a functional neck dissection. All of us are aware. Depending on what we preserve, not what you take out, what we preserve, there are 3 types. Type 1 is when the spinal accessory nerve is preserved. Type 2, if you preserve the interjugular vein and the spinal accessory. And if you preserve all 3, that's the sternomastoid, the interjugular, and the spinal accessory, it becomes a type 3. Many a time it's possible to preserve all 3, but if you're doing a unilateral, at least try and preserve the spinal accessory because it leads to a lot of functional disturbances if you sacrifice the spinal accessory. All this provided oncologically you are happy with the operation. These are certain incisions which are made, the Cocker, the Hayes-Martin, etc., etc. You can put 2 parallel incisions, one starting from the symphysis venti going up to the mastoid, and then you can avoid this and put another incision along the lower border. That's called a McPhee. Various incisions are described depending on what you're familiar with. These are certain neck dissections which were in vogue, the anterolateral, the supraomohyoid, etc., etc. Today, a lot of nomenclature has changed, so we won't concentrate on this. Of importance, I said, look for try and preserve the accessory nerve. The SAN in this picture is the accessory nerve. Rule of thumb, this is the sternocleidomastoid. This is the trapezius. This is the right side, obviously. So start looking for the accessory nerve 1/3, 2/3. That is where the upper 1/3 of the sternocleidomastoid meets the lower 2/3 and where the upper 2/3 of the trapezius meets the lower 1/3. That's where usually you'll find the spinal accessory nerve which needs to be preserved. It's close to the great auricular nerve. Unfortunately, what happens when you start operating the posterior triangle, you find there are so many nerves, cutaneous nerves, which come from the posterior border of the sternomastoid, and you think everything is the spinal accessory. It takes a little time. If possible, try and preserve the spinal accessory nerve from the functional point of view. There is a this is a 2019 paper, February 27th. It says, how to manage the neck in squamous cells. These the ASCO guidelines. Recommendations again. Look at this. If you have a C, T2 to a T4 lesion without neck nodes, a CN0, you do an ipsilateral neck. What nodes are removed, I'll tell you. I repeat, even with, so partly answers the gentleman, what the gentleman is saying. Even if you don't have neck nodes, if your tumor is T2 or T4, do an ipsilateral neck. Whereas, if your tumor is CT1 and an N0, you can get away with an elective neck. There is a little different, I'll show you in the next slide. However, certain questions are answered if you have a very reliable ultrasound neck you can offer close surveillance. Not all of us are so lucky to have good ultrasoundologists. So two things, either you can do a neck dissection, what levels I'll tell you in the next slide, or close surveillance provided a neck ultrasound surveillance techniques are available. Most of us are not so lucky, so we'll go ahead and do, even for a CT1, we'll go ahead and do a neck dissection. What sort of, I'll tell you. An ipsilateral neck with a CN0 will be 1, 2, 3. Level 1A, 1B, 2, 2A, 2B is controversial, 2, 3. In the days gone by, a level 1 to 3 was called, what was it called?
Suprawards.
It was called an SOH. It was called a supraomohyoid neck dissection. Today, you can, these are interchangeable terms, but it's safer to call, what will I do? I will do an elective functional neck. I'll take out level 1 to level 3. Whereas, if you have a C that is a node positive, 1, 2, 5, to 4, at least 18 nodes must be taken out. And level 5 if there are multi-station disease. So certain recommendations, the minute you have a node positive neck, 1 to 4 at least. Level 5 depends if there is multi-station disease, and the number today is 18. I said 15 plus in my previous slide. There are definite numbers today. You must try and take out, a pathologist must find at least 18 lymph nodes. Otherwise, it becomes an inadequate dissection. To summary, I just put a summary slide. If you have an N0 neck, even with the T1 clinically, you do a selective neck dissection, 1 to 3. Controversy whether you avoid the 2B. Some of us remember what a 2B is, right? And there must be at least 18 lymph nodes in your dissected specimen. From surgery, can we move on to radiation? Yes or no?
Yes, sir.
Okay, right. Okay. Very quiet audience today. Right. There are radiation usually used in the adjuvant or the neoadjuvant setup. Sometimes you can give palliative radiation, but mostly either in the adjuvant. As a surgeon, I would prefer adjuvant radiation because it's much more difficult to operate on an irradiated neck. Usually it's the external beam source. The gamma rays are used, and the source of radiation is the cobalt-60. You can give brachytherapy for tongue lesions. You use iridium tubes kept in cesium packet, so to say. The outer tube is cesium, and the radioactive substance is the iridium. Brachytherapy is accepted for tongue lesions. What is newer is IGRT and IMRT, that is image guided or intensity modulated radiotherapies. The idea of these is you try and avoid collateral damage. You try and reduce the bad effects of radiation or the amount of radiation which goes to the normal tissues. You try and avoid, reduce, I'm sorry. You can't completely prevent. The usual dose is 4,500 to 6,000 centigrays. The common mistake students do is to say 6,000 grays. If you give 6,000 grays to a human being, be fried. So it is centigrays. It is given in fractions, about 150 to 200 centigrays a day, 5 days a week. Saturday, Sunday, usually radiation is not given. If you're interested, please find out what these two terms are, what is hyper and what is subfractionation. Also, please try and find out what is a linear accelerator, famously called a LINAC. What is a collimator? It is useful to know these terms because otherwise, you know, a lot of things you're imagining. If you know these terms, at least it tries and makes a little sense as to what a collimator is, what is a linear accelerator, what is hyper, what is subfractionation, what is IGRT, what is IMRT, etc. These are certain recommendations. The 2018 update, which says postoperative radiotherapy, any T3 or a T4 lesion, you must give radiation. If you're not happy with the margin or you can't reoperate and clear it, even with additional margins, give radiation. Perineural lymphovascular, obviously, give radiation. 2 or more positive rods in the specimen, give radiation. Chemotherapy, I said, is given concurrent. Cisplatin is given 100 milligrams per square meter every 3 weeks. ENE, we said, is extranodal extension. EC is extracapsular extension. So there, in the surgical specimen, if you find a positive surgical margin, etc., with radiation, give concurrent cisplatin. Cisplatin is the most commonly used drug for giving adjuvant chemotherapy in oral cancers. One complication I'd like to describe discuss in radiation, and that is osteoid necrosis. Heard, not heard? Heard, not heard? Osteoid necrosis. Heard or not heard? Nobody's talking. Have you guys heard of osteoid necrosis? Yes or no?
Yes, sir.
Okay. I don't know how much you guys know, but we were supposed to read about osteoarthritis, right? Okay. I have some problems sometimes. Give me a minute. Right, okay. Today the classification is into 3 types. A and B depending on, is there a pathological fracture? Sorry, without or with a pathological fracture. A resolved, healed type of osteonecrosis is type 1. If you have a chronic, persistent or non-progressive type of osteonecrosis becomes type 2, again without and with a pathological fracture. And if there is an active progressive disease, becomes type 3, 3A without a pathological fracture, 3B with the pathological fracture. And the pathognomonic sign of osteonecrosis is, apart from the pain, etc., is that the patient keeps complaining of a persistent discharged sinus. So if you have a type 3 disease of osteonecrosis, according to this classification, patient gives a classic history of something like bone spicules persistently coming out with severe pain. Why do you get ORN, osteonecrosis? Why do you get this? One of the things that happens is irradiation-induced fibrosis. Irradiation-induced fibrosis is one. The osteoblastic activity gets decreased is one cause for osteonecrosis, along with an increase in the myofibroblastic activity. The blood supply is decreased because of the radiation, and osteonecrosis is a complication which is very peculiar to the mandible. You don't get usually osteonecrosis of the femur if you irradiate for an osteosarcoma. The blood supply of the mandible is very tenuous because of the inferior alveolar artery alone. So if the inferior alveolar artery undergoes fibrosis, or end arteritis, the term to use, the facial artery is not enough to maintain the blood supply of the mandible. So you can get osteonecrosis, and addition of cisplatin increases the chance for developing osteonecrosis. In the days gone by, we used to extract, it was conventional to extract all teeth before the patient went for radiation. So your patients became edentulous, no longer needed. Past 5-10 years at least, as long as you maintain the dental hygiene, the chances of osteonecrosis become less. So there's no need to make the person edentulous. How do you prevent? 3D CRT is 3-dimension confirming radiotherapy, wherein you try and reduce the unwanted radiation to the mandible. IMRT, I said, intensity modulated, and improve the dental hygiene. I suppose we are finishing. Just wanted to show you one slide. May not be exactly related to oral cancers, and that is, have you guys heard of this? I came across this reading some other topic, not oral cancers. Have you heard of this term, abscopal effect?
Yes, sir.
What is it?
if the tumor is irradiated, the tissue, the cells will lysed, and it induces an immunogenic effect on the rest of the tumor cells. So
True.
it is,
Yes,
it is an
true.
ascortic.
What the gentleman said is true. Perfectly true. What is this? This is new to me. I came across this while reading for breast cancer in the book. Right? Never heard of this. If you give localized radiation, you find it is supposed to stimulate systemic anti-tumor effects. So there is a systemic good effect which happens, right? And that is outside the field of radiation. That's apparently called an abscopal effect. So I've tried to summarize oral cancers with special emphasis on the tongue, few things here and there. I hope something has been useful. Any questions? Otherwise, we can slowly stop. Any questions, please? No questions? Right. Okay. Thank you very much. Have a nice day.
But Srinivasan, you want to comment?
No, so no comments, sir. I was a PG student today. There's a lot of new things there. And the
Lot of
beauty
things
is,
for me also, sir.
and the beauty is, I saw his father is also listening to him, the great man, Professor Ballal, listening to, because I would like to listen to his lecture long time ago of obstructive jaundice, and he comes and takes that too in the postprandial period. So he was also in the line listening.
Yes.
So great lecture, sir. Beautiful, sir.
Thank you very much, sir.
And one
Any
thing,
comments from the audience?
Good, bad, or ugly, doesn't matter.
never a bad comment.
If no comments, sir, then we shall close the session. Thank you so much for
Right, sir.
your
Thank you very much, sir. Thanks, sir.
Thank you, Radhakrishnan, sir. Thank you.
Thanks, sir. Thanks, sir.